Welcome to Diagnosing Health Care, a podcast featuring thought-provoking conversations about the latest legal, policy, and regulatory issues in healthcare. While these issues may seem like hurdles, we'll also look at the business opportunities and solutions that exist. Diagnosing Healthcare is brought to you by the healthcare lawyers at Epstein Becker Green, a leading law firm that has more than 40 years' experience serving clients in the healthcare industry nationwide.
Today on Diagnosing Healthcare, we discuss the passage of President Biden's $1.9 trillion coronavirus relief package, the American Rescue Plan, which includes money for rural hospitals, billions for COVID-19 testing and contact tracing, as well as extra subsidies to help people buy health insurance coverage to the Affordable Care Act plans. Hello and welcome. I'm your host, Tim Murphy, an attorney at Epstein Becker Green's Healthcare and Life Sciences practice, based out of our Boston and Washington, D.C. offices. On March 11th, President Biden signed into law the American Rescue Plan, a sweeping $1.9 trillion aid package aimed at rescuing the nation from its pandemic slump. The ambitious package, which tackles pressing public health challenges, is a victory for the Democratic Party and fulfills one of the president's central campaign promises to expand the Affordable Care Act. On today's show, we're going to talk through the relief package, as well as visit what that package may mean for future legislation. This episode is a follow-up to episode 17, where Mark, Philo, and I discussed the 117th Congressional Healthcare Agenda, including the prospects for additional coronavirus relief and what that would mean for stakeholders. We'll revisit those predictions and make some new ones at the end of the podcast today. If you like what you hear today, please subscribe to the show, Diagnosing Healthcare, which is available wherever you get your podcasts. We have two guests who have returned to the podcast to join today's discussion. First, we have Mark Lutes, chair of the firm and a member of the firm's healthcare and life sciences practice in Washington, D.C. Mark helps private equity sponsors understand the impact of regulatory and compliance concerns with their healthcare industry investments, as well as representing stakeholders throughout the healthcare system on a variety of issues. Mark, thanks for joining us and welcome back to the show.
Thanks, Tim. Looking forward to it.
We also have Philo Hall here today. Philo is a senior counsel in the healthcare and life sciences practice in our Washington, D.C. office. Philo draws upon nearly 12 years of experience in a series of federal government health policy positions. He brings insight into the legal, policy, budgetary, and political factors that influence federal agency decision-making. Philo counsels healthcare providers, health-related companies, financial institutions, and investors in the healthcare industry on trends and relevant federal and state public policy developments. Welcome back, Philo. Thanks for being here.
Thank you, Tim.
Gentlemen, a lot of time and ink has already been dedicated to discussing the economic relief of the stimulus portions of the recovery plan. But today, I think we're going to narrow in on the healthcare specific portions of the legislation. To that end, I think it makes sense to think about the various healthcare provisions as they break down into what I think of as four buckets. The first is a support for public health activities such as vaccination, testing, contact tracing. Two is direct and indirect funding for specific provider types. Rural hospitals come to mind. Three is funding for federal oversight activities, including the former stimulus or CARES Act funds that came out. And four is changes to the public insurance programs. While I suspect most of our conversation is going to narrow in on the final two buckets, I did want to touch upon the first buckets in our overview. To kick off the discussion, I wanted to highlight the funding for the public health activities. The recovery plan allocates approximately $48 billion to HHS for COVID-19 testing, contact tracing, and mitigation efforts, $6 billion to purchase and develop vaccines and therapeutics, $10 billion under the Defense Production Act to increase production of COVID-related medical equipment, supplies, PPE, and vaccines, and $500 million to fund FDA's review of vaccines, therapeutics, and along with supply chain management activities. So that includes reviewing areas where the vaccines are being produced and so on and so forth. I think that most of this is pretty straightforward. It's a lot of direct spending that we expected the federal government to have to assist with sort of the rollout of the vaccine process. I did want to ask Philo about the additional relief in the package that is there for certain provider types. Could you give our listeners an overview of that relief?
Sure. Thanks, Tim. I will just highlight a couple of provider areas because I think it is interesting. You know, we're doing these health provisions in the American Rescue Plan, just passed, and we also keep in mind that Congress just passed the massive Consolidated Appropriations Act in the last week of 2020. So it's rare to see such two large bills being passed so close to each other. There are a lot of healthcare provisions in the Consolidated Appropriations Act. So it's very interesting to see which providers and which sectors got assistance in the healthcare field in this American Rescue Plan. Two that I want to highlight. One is targeted assistance and relief for nursing homes for different kinds of infection control and patient and employee safety in nursing homes, responding to the pandemic and preparing for future pandemics. And I think that's interesting to signal that of all provider sectors, I think there will be some scrutiny and focus on the nursing home industry, on SNFs, and how they can be better prepared in the future. This is passing at the time where, let's say, like on March 25th, the House Ways and Means Committee held an oversight hearing on the performance of nursing homes during the pandemic. It sort of focused on the different types of nursing homes and who was investing in them. But there was a lot of criticism and attention over different performance standards of how those nursing homes performed in the pandemic. So I think this tells me nursing home preparedness is going to continue to be an active issue, both for preparing and for investigating what happened in 2020. The next provision that is very interesting, to me at least, is the $8.5 billion in relief for rural healthcare providers. And I say this because here at Epstein Becker Green, we've been advising clients for a long time over the last year on the Provider Relief Fund. That's $178 billion total that Congress provided to cover the COVID-related expenses and COVID-related losses for Medicare, Medicaid providers, basically all health providers in the country. There was some criticism over how HHS distributed those funds over the last year. Some were targeted funds by application, and others were funds that just automatically went out to Medicare and Medicaid providers, and then providers would have to see if they really had losses to justify them, or else give them back to HHS. And so it's interesting how Congress set aside this sort of different, separate program to be run differently than the Provider Relief Fund. It's only $8.5 billion, but we see that Congress sees a need still in rural health care. And it is a program that providers obtain the funds through application. So HHS will not automatically be sending out funds based on a provider's rural status. Rather, the provider has to apply and show, what their losses and expenses are. We expect to see details on that from HHS later this spring, and we'll see what the details of that program are. But it is an interesting line that Congress is asking HHS to walk. On the one hand, you want to be more targeted, more deliberative in giving the funds to those who are in need. But on the other hand, the more deliberative and careful HHS is, the longer it takes to get those funds out to hospitals in need. And sort of the last thing sort of related to that, we're talking about the Provider Relief Fund and all this money that has gone out to providers from HHS. The American Rescue Plan provided a new $5 million to the HHS Office of the Inspector General to conduct oversight on how HHS COVID relief funds have been distributed and used over the last year.
I found that to be very interesting. Turning to Mark, I'm going to follow up with a question for you about that, although I did want to comment that it has felt a little unfair to providers that receive some of this money, a little bit like building the plane while it's in the air on what their obligations and reporting are going to be there with respect to the relief funds. But Mark, I thought that the inclusion of increased funding here was of interest. Federal oversight over the COVID-19 fund certainly has been interesting to date. Anything that stakeholders should be aware of, or that you think that they should be thinking about the allocation of funds and how the oversight's going to go?
I think that stakeholders have to understand that even though, as you have put it, they were called upon to build the plane in mid-flight, that there are potential serious ramifications as OIG seeks to account for this. OIG has authority, has had for a number of years authority to issue civil monetary penalties for fraud involving HHS grants. Courts have held that the False Claims Act applies to HHS grants. We've already seen the DOJ involved in seeking its first indictment for misuse of provider relief funds. So compliance and documentation in that space is something that can't be ignored, although, as you rightly point out, this was $150 billion, I believe, that went out within the first 10 months with relatively little guidance. The standard that HHS asked providers to apply is to use those funds to cover healthcare related expenses or lost revenues that are attributable to coronavirus, but not reimbursed by other sources. It is something where the instructions relative to the interpretation of that have been sparse and vague. Providers do face a little bit of uncertainty as they build their documentation, but it's something that I think, to your point and Philo's point, the documentation around the expenditures of those funds shouldn't be ignored.
Turning now to what I consider to be the most interesting portion of the recovery plan, the changes to the public insurance programs. Philo, I think they break down largely into the ACA products and the Medicaid expansion. But could you give us an overview of what those changes are?
Happy to. And yes, this is a very exciting and interesting area because this starts to bring in and implicate some of what President Biden campaigned upon regarding ACA expansion. Regarding the ACA marketplaces, the exchanges, the law generally reduces the cost of marketplace coverage for all subsidy eligible individuals and families by increasing the value of the premium tax credit subsidies at every income level. For example, the value is increased so that individuals with incomes between 100 and 150% of federal poverty level will now pay no premiums. Households with income levels above 400% of the federal poverty level are newly eligible for the premium subsidies. And there's an overall cap on how much total household income can be devoted to these marketplace premiums. And that now no household will pay more than 8.5% out of their annual income for the marketplace premiums, and the levels go down at lower levels of income. So that's on the marketplace side. And on Medicaid, there are a number of Medicaid provisions which increase the federal matching rate for some targeted specific services that states might do for vulnerable populations. But the big headline, I would say, is the next chapter on encouraging, let's say, the 12 remaining outstanding states that have not expanded Medicaid to take the steps to expand Medicaid. And let's just review in the current law, states that expand Medicaid have their federal matching funds increased to 90% for the expansion population. And under the American Rescue Plan, states now will receive, if they make that expansion, they'll receive 2 years of federal matching funds at 95% of cost for that expansion population. So for this option does not expire. It's available at any point. But when a state does expand to that population, they will get 2 years of federal matching rates at 95%. And that is, I think, sort of the high profile, interesting question, because that begs the question now on what states will do.
Well, since you've begged it, in your crystal ball, do you have any opening thoughts on whether states are going to be expanding, these 12 states that are left? I will note on that note that we do have 2 states that have elected to expand but haven't fully implemented it yet that are also potentially impacted here. Right.
And I will, I don't have a crystal ball, but here's what I look for. So Tim, you mentioned the 2 states that are in the process of expanding now. It's Oklahoma and Missouri. And interestingly, those states are moving towards expansion because they achieved it through a voter ballot initiative. This is not action by the legislature. So the next thing to look at is states where ballot initiatives are underway. And there's ballot initiatives gearing up in South Dakota for 2022. And in Florida, there was work on a ballot initiative earlier. We'll see if that comes back. The other things, let's look at Wisconsin, Kansas, and North Carolina. Those are states with Democratic governors that have proposed expansion, but they have Republican legislatures so far that have rejected any expansion. And then Mississippi, I understand that the topic of expansion was at least debated in the Republican gubernatorial primary in 2019. I consider that interesting that even among the Republican Party in Mississippi, it's up for debate. But these are just sort of things that I sort of watch. One can watch on a state by state basis, fits and starts. A governor might support it, but it might be absolutely no chance of support from the legislature. That's sort of year by year tracking of this. But Tim, I happen to recall that, going back to early in the ACA days, you were also very closely tracking and assessing then what might lead states to ultimately do expansion. So I wonder if you have any global thoughts on trends and likelihood for states to adopt the expansion.
Yeah, I think that it is just economically too good a deal for states to continue to pass up forever. It's probably going to take time, and the further and further away we get from the Obama years or from the association of the expansion with Obamacare, the more likely it is that we're going to see expansion in those states. But I do think that over time we are going to see all, if not almost all of these states expand. It may take another another decade before we see it. But I do think we'll see everybody expand eventually. It's just monetarily too good a deal for the state to sit on the sidelines for that federal spending.
A good example or precedent of that is when the Medicaid program was created in 1965, states could choose to adopt it, or states had to take proactive action to adopt it. And the last state to adopt the Medicaid program was Arizona, which I believe happened in about 1982. So almost 20 years. So some of these states might be operating on a similar time frame.
Right. And I think the political cultures in each of those states is going to sort of dictate what that timeline ultimately is. As you see, Arizona's already expanded, and so they did not take 20 years to implement this time around. Mark, we just talked about sort of the potential for Medicaid expansions, that we have ACA credits that are more generous, which might mean we have additional people taking up coverage. I was hoping you might be able to put that in context for what healthcare providers and other stakeholders in the system might be thinking about for these changes.
Tim, I think as I hear you guys talk about it, reflect on it a little bit, the biggest question is going to be how permanent are these changes and expansions of these coverage programs? Can healthcare providers and other actors in the space look to the positive revenue impacts only in the short term during the course of a public health emergency, or can they assume that those populations will enjoy coverage and the financial barriers to seeking care will be mitigated as a result over the long term? I think what we want to do there is watch Congress really closely throughout the balance of the year to understand whether these temporary expansions can be made permanent. I think Speaker Pelosi has signaled an intent to try to do that and signaled that she thought that the pay for on that should be prescription drug pricing in some respect. It's pretty clear that the current slim Democratic majority sees a narrow opening here to achieve potentially long-lasting change and expansion of coverage, just building on what was done here in response to the public health emergency and making that permanent. It's certainly fascinating from a sort of overall historical perspective and a trend of watching healthcare policy that what was impossible to do or very difficult to do through the front door, an announcement about expanding coverage became more feasible to do in the context of financial relief, in the context of a public health emergency. And so maybe we have sort of an echo of the New Deal, that social change gets ushered in under the backs of or under the auspices of economic relief. It's certainly something that, given the millions of potential new enrollees in the exchange plans and beneficiaries of Medicaid, that would potentially be better able to afford services from the providers in the system with that help. It certainly makes sense to continue to watch that and understand that that's a potential macro tailwind for the healthcare industry that will get a really good idea whether it stays permanent over the next couple of months.
I think that's right, Mark, and it's going to turn us to our discussion of what to look for in the future before Congress and the administration with respect to these issues. But I do, before we jump into that sort of crystal ball, what's coming next for the 117th Congress and the Biden administration, I do want to say that we're recording this on March 26th. Should come out next week, either the 31st or the 1st. If you're listening to this, some of it may be stale. In fact, I'm about to ask Philo a question about the sequester, which I think that there was some action on yesterday. So when we were kicking around what to talk about in this section, it's already been updated. So everything is moving pretty quickly. But one of the things that we try to look to is where there are pain points or timelines that have to be, or problems that have to be solved by a certain drop dead date by Congress. And the first of those was, or I think it still is, because I don't think that it's fully executed yet, but the sequester was to expire at the end of the month. And there's a couple of other healthcare deadlines coming up in the next 2 years that are certainly chances for action. And I was hoping, Philo, you might be able to tell us a little bit about those.
Certainly, yes. And the sequester relief is a perfect example to sort of illustrate the principle, and then we can talk about how that helps us project or plan what else Congress and the Biden administration will have to face in the next year and a half. As a reminder, and again, we're in the midst of the legislation now, and this has been a confusing week for everyone tracking sequestration relief. But as a reminder, there is a statutory provision in law that applies across government Medicare program spending that reduces Medicare payments to providers and to health plans by 2%. That is a broad deficit reduction measure put in place by Congress some time ago, going back to the Obama years. And as an element of COVID relief passed early in 2020, Congress suspended the sequestration. So the sequestration reduces payments. Congress suspended the sequestration as, many providers either had extraordinary new COVID-related costs, or many providers were just had their capacity and their utilization plummet. They were in financial distress. So Congress thought it would be a nice, financial assistance to not take an extra 2% off of any reimbursements. The suspension of the sequestration was extended once and then extended again to run through March 31st of 2021. So that means that April 1st, Medicare payments will start being reduced again by 2%. Well, Congress is not quite ready to start collecting those sequestration reductions again. So Congress has been working to try to extend that suspension of the sequestration reductions through 2021. The House passed a bill last week to extend the suspension through 2021. Yesterday, the Senate passed its version to do the same thing, except there are some details in the bill that I don't need to get into. They're very much inside hospital disproportionate share payment, detailed provisions of that. So the point is that the two bills are different. So the House has to now repass the bill passed by the Senate yesterday on March 25th before the extension will be carried through the year. Problem is that the sequestration is supposed to go back into effect on April 1st, and the House is not planning to take up this legislation until April 13th. So what we hope and expect is that congressional leadership will work out a deal with the administration to announce that CMS will hold all claims beginning April 1st until the law is finally passed by the House and then signed by the president, again, the second full week of April, so that, providers and plans may have to go up to 2 weeks without payments, but when they come through, they will be at the full level without the 2% reduction. You may see or hear news about that if you're in the provider space. The relief is expected to come, but it has taken Congress up until the last minute to figure out how they're going to do so. Now, Tim, you sort of teed me up to talk about what else is going on. So again, all this action happening at the last moment, the last week of March, because that's when Congress set the deadline for this relief to expire. I always like to look at what are the timeline markers that Congress sets for itself for when benefits or assistance expires, because that's when the motivation will be for Congress to re-up or readdress that issue, again, normally at the last minute. A few that are interesting. One is the Puerto Rico Medicaid program, which unlike state Medicaid spending, which is entitlement spending, Puerto Rico and the territories' Medicaid programs are funded like a block grant. It's a separate appropriation from Congress. And under current law, Puerto Rico's Medicaid funding, therefore, is expected to decrease by about 2/3 at the end of September of this year, of 2021. Congress has disputes about, maybe what the future of the Puerto Rico Medicaid program should look like, but I think there is agreement that Congress does not want the Medicaid program in Puerto Rico to be cut by 2/3. And let's just recall that it is a very large Medicaid program. Puerto Rico has the same geographic size and population as Connecticut. So this is not a small Medicaid program. So that means that Congress, one way or the other, will be debating and extending Medicaid funding for Puerto Rico in late September. So that means there's a healthcare bill of some sort moving in late September. By the end of 2021, Congress will have to reevaluate healthcare provisions again. So we just talked about the expansion of the sequestration relief running through 2021. That means I'm sure that there will be a lot of providers approaching Congress in December of 2021 saying that they're still under distress and would like to see the sequestration suspension continued into 2022. How long this relief extends, that's not clear. There was a similar relief given to physicians under the Medicare program. So Centers for Medicare and Medicaid Services, CMS, was implementing a reduction through the conversion factor in physician reimbursements for 2021. For different specialists, it ranged from maybe 2 to 9% cut in payments. And Congress stepped in to mitigate that cut by, let's just say, roughly cut that reduction in half for most providers through 2021. The sequestration relief will expire at the end of 2021, and this assistance for Medicare physician payments will expire at the end of 2021. So just like as Mark was saying earlier, COVID relief is an excuse for financial assistance that providers may not otherwise expect or get on a normal basis. Congress has to decide how long to extend that assistance, and a decision point for Congress is going to be at the end of 2021. Will that relief to providers end, or will it continue? So there's another time and vehicle for a healthcare bill.
And then I think that the final one that we had talked about, or at least to consider, is at the end of 2022, which the current premium increases for the ACA plans will expire. But then if we wait until December 2022, we're going to have a lame duck Congress trying to get that through, which might signal why Speaker Pelosi has already put that on the priority list to try to make permanent at an earlier basis.
Yeah, exactly. It's very interesting. It is sometimes a challenge to remember what consumes the thoughts of congressional leadership when they think about issues, as they think about floor time. They really just can't do a few healthcare bills a year because there are so many other issues demanding their attention. As we saw with sequestration legislation this week, when Congress really focuses on an issue, it is really all consuming. So yes, perhaps Speaker Pelosi is trying to fit as many healthcare legislative proposals as possible into action towards the end of 2021. Because as Mark said earlier, she has invoked making these current ACA expansions permanent, and she's invoked paying for it through prescription drug pricing reform. So that's bringing together a lot of the major elements of the Biden platform all at once. So if other congressional leadership goes along with that, it will be an extremely busy and exciting late 2021.
Philo and Tim, let me ask you on that, since you opened the door to it, which I think it's important to take our thoughts in that direction. What do you think the lowest hanging fruit is in the prescription drug pricing domain to, generate revenue to fund these other priorities?
I'll take a stab at that. There's sort of two different ways to address it. I think in some other podcasts that EBG has put out earlier, late last year, we've discussed that there are a whole range of prescription drug pricing reform options, some of which are supported by Republicans, some by Democrats, some by a combination. There's a question of which prescription drug reform proposals might have bipartisan support. But there's a second, I think what you're getting to, Mark, is a second question of which prescription drug pricing reform proposals could generate savings for the government and likely have the support of the Democratic caucus. One thing that Congress will be thinking of is if you have a Democratic majority in Congress and a Democrat in the White House, what is on their agenda and to-do list? And I think the low-hanging fruit, I would say first and foremost, is allowing the HHS secretary to negotiate with pharmaceutical manufacturers over the prices of prescription drugs that are covered under Medicare and Medicaid. That's been a priority for many since the implementation of the Medicare drug benefit. One could say, if you want to be a little bit more modest, it could be reform of Medicare reimbursement for drugs administered in physicians' offices. These are what are called Medicare Part B drugs. And I flag that because both the Obama administration and the Trump administration saw Medicare Part B drug reimbursement as an inefficiency and a problem, and they each proposed regulations to test alternative means to reimburse for Part B drugs. And most recently, under the Trump administration, it was by tying Part B drugs to an international price index. The Obama administration faced a lot of criticism and withdrew its proposal. The Trump administration faced criticism and litigation, and now the Biden administration has put that proposal on hold. But I say that to mean that there is sort of a bipartisan agreement by successive administrations that Medicare Part B drugs is maybe a first place to look to generate savings. The big grab, I would say, what's both low-hanging fruit and a long-standing objective and could generate as much savings as Congress wants, is allowing the Secretary to negotiate directly with manufacturers over both Medicare and Medicaid drugs.
Thanks, Philo. I think that is a good back of the napkin of the various options that are on the table. Following up on the conversation we had about potential movement because of deadlines, there is one other bill I think that there's a good chance that we see move this year, and that's an infrastructure bill. And I know, Mark, you had thought a little bit about the healthcare portions of that bill. I just wanted to take a moment to maybe highlight some additional spending that might come there. That
makes a lot of sense, Tim, for our provider clients to understand that in the so-called LIFT Act that we will see the House consider portions of throughout the spring and summer. Those early drafts include, literally billions in potential spending in infrastructure projects related to healthcare. $10 billion potentially for Hill-Burton construction and modernization. Another $10 billion for community health center, $4.5 billion for lab infrastructure, again, flowing from the pandemic realization about the strains on our ability to manage disease, being dependent on a robust laboratory capability. Yes, this is another instance where there's going to be a growth in the development of healthcare capabilities arising, a back door, if you will. The back door we were talking about before was the expansion of coverage as economic relief in public health emergency, expansion of insurance coverage options. And here, as Congress thinks about lifting the economy through infrastructure investment, healthcare is going to be a material part of that, and something that provider clients may want to think about how they might access to enhance their ability to serve their communities.
And I think that also goes to Philo's earlier point about the amount of floor time that Congress actually has to dedicate solely to healthcare related bills. I think the stimulus bill or the recovery plan that we talked about today, the potential infrastructure plan, these are other ways without having to dedicate floor time solely to healthcare spending or changes that we might see additional action under. But with that, I think we've sort of run up against our time for recording today. I want to thank you both for joining. It's been a great conversation. I look forward to the day when we can have them again in the office together. Thank you for joining. Thank you to the audience for listening in. Please remember to subscribe to Diagnosing Health Care wherever you get your podcasts. We look forward to speaking to you again soon.
Thank you for listening to Diagnosing Health Care. For show notes on today's episode, additional episodes, and more insights on trending issues in healthcare, please visit diagnosinghealthcare.com and be sure to subscribe on your preferred platform. The Employment Law This Week and Diagnosing Healthcare podcasts are presented by Epstein Becker Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of the legal services to be performed is greater than the quality of legal services performed by other lawyers.